Hey, everybody, the doctor is in.
Oh, the doctor is in.
The doctor is in.
Dr. Keith, you're the doctor on duty till Mo gets here, and here she is.
I see Mo's right on time.
Right on time, right on time. She'll be here in a second. So, the doctor is in. The doctor is in.
Yay, everyone's here.
Getting all here.
Gangs, this is like a family reunion, man.
I know.
You know, right?
Look at everybody. Everybody has like the right color on. I'm gonna go change my shirt.
I know it's pink month, dude. It's
I
pink
know,
month.
but I had blue, and then I have a little bit of pink in my blazer, but you can't see it.
Well,
It's perfect.
But blue is your color. You got
Yes.
it
Right.
Yeah, blue is your headshot.
Oh, hold on for a second. I do have. There it is.
Hey.
There it is.
See, it's perfect.
That's right. It matched. It matched. Okay, so good. I got the memo. I forgot what I had layers on.
It's so good to see you all. See
I
your
know
Yes,
our
it is.
gang's here, our favorite peeps, Mo, are here.
I got too. It's so much smiling energy. I don't even know how I can even take it. There's too many smiles out here. It's just like it's too much energy, too much positive energy. It's overload.
You know you love it.
We did a show about toxic positivity. Wait a minute now.
Because I'm telling you, because you go through the whole day and then you don't get a lot of positive energy, and then all of a sudden it's like it's refreshing. I don't even need coffee.
Oh, well, this is nice for us too. You get caught up in the to-do list, and then we have something like this kind of a conversation to look forward to. I wish we were all in the same room in real life, but I'll take it.
I know.
Okay.
Yeah, I know. Mo and I were together at the Nada wedding. We had the Nada wedding on Saturday, and we did a special.
Congratulations on your daughter's wedding.
So, I've only talked to Haley once since then, and she was pretty grogged out still. She was getting a tattoo of their wedding logo, and that's what woke her up.
Oh, okay, yeah.
Too
I bet that would.
I know.
Let me tell you, it was not a good time because it was amazing. It was epic, and yeah, it was beautiful. T. Yeah.
Too, not a wedding. So Melissa, why are you here? What are we talking about?
I'm so excited. First of all, thank you for having me back on Doctors. And I love having these conversations with you guys. And I launched a new series on my Dear Cancer, It's Beautiful podcast called Your Voice, Your Health, because I just feel like there are so many important topics related to advocacy that I wanted to kind of make a special spot for it, a special home for it, if you will. And I thought it would be important to kick it off with step therapy, because this is something I never even heard of before. And as I started to scratch the surface, I'm like, this affects everybody, not just those with breast cancer, but our parents, our children. If you need a prescription, if you need treatment for anything, it's going to affect you in one way or another. So I wanted to kind of peel the layers away.
Yeah. So for the people who don't know Melissa, she is the one and only cancer fashionista. She's also my first triple negative breasty friend, sister. And we met when I was like maybe a year out and you just finished treatment. And then we have my Dr. Keith, our co-host for our Love Your Bones show, and our friend. And we're so glad to have you. And
Thank you. I'm glad to be here.
I didn't have any idea what step therapy was until you told me about it like a month ago, right?
Right. Like I remember when I started to even kick the idea around, I started to ask some of my colleagues, like, do you know what step therapy is? And at first I thought, well, Ricky doesn't know what it is. And I'm like, well, that's all the more reason to do it if you don't know what it is, but it exists and it's a problem. And then what's so cool is that Dr. Keith was actually my first expert for my bone health series. So I just wanted to kind of bring it home and have him kick off my step therapy series, because, you just know so much about all these topics that affect the patient and quality of life. And I just felt like it was a really great way to start it.
It's interesting that you brought it up because.
What is it? Can
let's break it down.
Step therapy sounds like, could be a lot of different things to a lot of people.
Okay.
Right now, family homecoming, we have our own step therapy going
You ain't
on.
lying. So, matter of fact, if you pledge, you might have some step therapy.
We might have some step therapy.
I said, all I know is, So, like I was saying, so what's interesting, the key thing here is it's fail first. you have to fail on a treatment before you're allowed to go to the treatment that you may be best for you.
Okay, hold on. Fail what? Like,
Okay.
you have to take a treatment that doesn't work?
Well, you have to take a treatment that may not be the best treatment for you, because you remember, we're all talking about this shared decision-making process. You and the doctor get together, you and Mo get together, and you guys are talking about, according to your lifestyle and what you're doing, this might be the best treatment for you. But guess what? Because the insurance company is trying to save money. So what they'll go is say, first, before we put you on this, we want you to try this med because it's the standard of care. But they generalize standard of care for everybody. And we are moving into a personalized approach in treatment. And they don't care. First, try the one that may not be the best fit for you. If you don't do well, then you'll have to come back to us and we'll run you through the ringers. And then we may or may not give you approval.
That sounds really wonky.
Mm.
Well,
I
it's
know I
almost
kind of exaggerated it a little bit, but that's how the patient feels.
It's almost akin to doing the generic first. Like when we did our Neulasta conversations, we talked a lot about this. Remember, Ricky, when we first started, it was COVID and people couldn't get Neulasta, right? And so there are always these sorts of barriers where they try to start with the cheapest thing and then escalate to, the more expensive thing. And from a psychological framework and from a therapeutic framework, we should start with the least toxic thing and then escalate to the most toxic thing. Like that makes sense,
right.
But not just the dollars and cents part of it with, you got to fail on this before you can get that, you can't get that H2 blocker until you fail that, till you fail that Prilosec or whatever, and so it's really, we see a lot of people with reflux and other things. You have to fail, right?
And it's really like
cancer. We're talking about cancer.
But what Melissa said, this impacts everybody.
I know.
And so there are people that can tolerate, they can stay on a treatment and kind of work through this whole which one is best for you. But when you're dealing with a cancer patient, and there's a critical period of time where you're going to treat, and then they're going to put up these obstacles that interfere with your ability to receive the best care. Yes, it's really scary for a cancer patient.
It's scary for cancer patients, especially for the metastatic community, because they don't have time. And also think about all the additional toxicity that the medicines that you need to try first could, it could end up doing more harm than good. Isn't that sometimes the case?
Yeah.
All right. So I'm really
No drug is without a side effect, Melissa. You're right. Go ahead, Ricky. You said you're really.
I'm really flabbergasted here. So I'm going to get a drug that may not work. It's less than optimal. And I'm going to have to try it out.
Right.
To see if it makes me better. And if it doesn't, I have to wait till it doesn't work, till my cancer progresses to get another drug that works.
Well, it's not necessarily till your cancer progresses or there's no change. But something that's very important is that it's kind of binary, just kind of off and on or black and white, but it's a little bit more than that, because now it gives them the opportunity to slow roll the process. So, okay, this doesn't work. I don't feel good on it. It's interfering with my daily living. It could cause harm to me, but they're looking for you to do all of this. And then you have to go through the bureaucracy.
So whose brilliant idea was this? Is this an insurance company brilliant idea? Like, why are we doing this?
Well, if you want to look at
What's the
I'm
purpose?
going to say totally. I'm going to say pretty much totally, right? And the drug companies as well. But Dr. Keith, you can certainly weigh in. But I mean, it's across things, not just for cancer. We see it in diabetes. You see it in hypertensive agents. You see it in the whole Ozempic craze and everything else right now. You can't
and even skin conditions. I read this. This is one of the reasons I wanted to unpack this, there's a Washington Post article where I believe there's a young boy who had a horrible itchy eczema skin condition and ended up almost suicidal because they couldn't imagine. So it like, when I say it affects everybody, it affects everybody.
This is a good policy discussion, you know, and I think when we have it again, and when we talk about policies and things that we can do from a policy standpoint, this would be one that would be impactful, I think, across healthcare as a whole, is to really try to advocate for less of this and more of that personalized approach that Dr. Keith was talking about, because in the era of precision oncology, you should be able to receive precisely what it is that you need with the greatest efficacy.
And so that's so important, is because we have these new drugs that are coming out that are based upon your genetic makeup. So case in point, we were talking about PARP inhibitors. And well, if you have a BRCA1 or BRCA2 mutation, then you're an excellent candidate for a PARP inhibitor. So does someone have to go through a treatment that's not going to work as well? And see, even the whole problem is as well.
Right, as well. To me, I want the best thing I can take for my cancer. I don't want to like worry that I'm not getting the best drug. So how often is this happening, and who makes this decision? The doctor.
So it's an interesting point that you say. I call it, there are 5 P's that are involved, and the letter P's, okay, not the green P's. We got the patient and the physician. That's a group. You got the pharmaceutical companies. Then you have the pharmacy benefit managers, and then you have the payer. So the pharmacy benefit managers are together. Now we know the doc and the patients are the ones that are supposed to be determining what's best for the patient. On this other side, the payer and the pharmacy benefit managers are saying, like, we're trying to save money. That's their objective, is to save money. And so what they've done is try to wiggle their way in between the patient and the doctor.
You
Now,
said something. Oh, sorry, go ahead. Yeah.
And the pharmaceutical company, the other P, is just sit down there, because guess what happens? The pharmaceutical company gets screwed. You know why? Because and I'm speaking general here. So if anybody gets mad, is listening, is like, oh, that's not true. I said, listen, generally speaking, that the PBMs can kick back money to the payer. So the money that's supposed to go to benefit the patient is kicked back to the payer. And the pharmaceutical company's not getting any of that money. They're just sitting out there just with their hands tied, because they can't do anything. They're under strict control. So it's a fight between the physician and the patient, and the PBM and the payer.
Well, what it does, though, is it creates more barriers between the physician and the patient, and the trust. It erodes that trust, because now this patient doesn't understand that, that doctor ordered that thing, but then a prior auth was required, and then it got denied, and then and then they think, okay, why is my doctor prescribing me suboptimal things, or things that are, that are not as specific, or how come I can't get the thing that doctor prescribed me? Why is my doctor not advocating for me? And so it creates a sense of friction, and in my humble opinion, because this is where the breakdown happens. It's not that physician doesn't have that patient's best interest at heart. It's that your insurance said, this is what you got to get, and you got to fail this in order to get to that. We see it with osteoporosis, right? With the drugs. And so it makes that relationship even more strained, because then it seems like that doctor's not advocating for that patient. And it's just not true. There are barriers and barriers and barriers. And you're absolutely right. That money that should go to that drug gets put back into insurance companies' pockets.
Raise a great point, Dr. Mo, and even, more concerning, especially because you are a physician, is you go to medical school, you get all this training, like you are the expert, and now you're being undermined, and you can't give your patient the care that they deserve and that you believe they should get. And that's a problem.
And it contributes to burnout, and it contributes to that breakdown of, physicians saying, you know what, I'm not doing this. This is exactly why people wonder why, doctors sometimes don't always go to the mattresses for their patients. It's because you get tired of prior auth after prior auth. You got charts to do, you got more patients to see. They're driving that volume. and it becomes a chart and not a person. And this is the breakdown and the demise of our healthcare system, and why it's not just me and you having this conversation like you're my mother or my sister or my auntie. It's like, nope, I got all these other things that I got to work through and check through that have nothing to do with you. And it just takes the patient out of the equation, unfortunately.
Well,
Yeah,
how do you even know that you're getting a suboptimal drug? How do you know? I don't know what these drugs are, right? How do you know?
the only way to know is to have a relationship with advocacy organizations that spend time, like we do, educating you about what your treatment options are. Because the average patient wouldn't know. They just said they trust you. If your doctor is saying we're going to use this, then I believe that my doctor is going to make sure it's the best treatment for me.
But they're not.
And I wouldn't blame the doctor, because the doctor's looking, the first thing is to like, well, and it's kind of, I go back to these PBMs and the payer, because they're kind of, if they weren't so sophisticated, you would call them sleazy.
You know what? Got a point. Yes, tell them more.
Because they have all these little ways of managing how you utilize. We can control the quantity. If we don't get them there, we can switch from a non-medical application. There's preferred authorization that comes in. And then after all those little tricks they stick in there, then they throw in step therapy.
And it's tricky, because when you look at the guidelines, and we always tell patients, if you want to know what the standard of care is, you go to the guidelines, right? So you got an NCCN guidelines. Nothing is in there about this. There are classes of drugs, and there are pathways and algorithms that are listed in those guidelines.
Yeah.
But this is not in those guidelines. It just says you should get,
What's preferred.
You should just get right. Exactly. And so it's a class of drugs, not the preferred drug within the class. And that can be problematic. And I think it's a very nuanced conversation, I tell you.
Because
there's so many layers to it. That's why, it's not just I wish that the four of us could talk about it, and then everyone listening could be like, okay, I know what to do now. There's so, and I encourage everyone to, and we'll put the link in here to listen to the podcast episode that I did with Dr. Keith, because there are so many great action points, but there are so many nuances to this. And one thing I learned as a patient is that and Dr. Keith, you had shared this with me, that it really, first of all, depends on who your health insurance carrier. It's gonna vary company by company. And if you're in a position right now, whether you're changing jobs or your partner is, to start with a new provider, one of the first things you want to ask them is if they have a step therapy protocol in place.
Right. That's something that everybody has to ask. They got to find out what the protocol is. Because
don't ask your doctor.
And then something that's interesting is that your employer could think that they're providing the best care for you, but it may not be the best care for you.
I know. How does my employer know anything about my care?
They won't. So
at work that I'm sick.
They're trying to save money. So that now we're not putting any weight on the employer, because again, the employer also can be fooled. Because here's the thing, you may cover some basic stuff, but if you go into some more chronic diseases, there's somebody in the employer or employee's office may not know the difference between just regular disease and chronic diseases, and they may just group everything together. You see that concept? Let's just bring everybody together into a food salad or a health salad, and everybody is treated the same way. And you can't do that.
Right.
Any questions in the chat, Ricky? I feel like people are probably going to be in an uproar about this one, because this is something that if you didn't know, now you know, but you should know and be aware of this for every condition that you have and every medication that you take, whether it's asthma, whether it's, for acid reflux, especially if it's for cancer, that there is almost always going to be this push for the generic, the first line that, may not be as specific, but that may work, there is a chance it may work. but
Yeah.
it really becomes a little bit more arbitrary and it seems a little bit unscrupulous when you look at it that way.
Yeah, but
I'm worried
I
about
want to push it. I'm not trying to beat them up.
Come on.
But what you said was, and this is, and I'm saying if there's a loophole, people will exploit the loophole. And I don't think it's fair that a pharmacy benefits manager who has purchasing power can get a drug
That's right.
for a low cost. The patient pays the standard cost, and the savings could be repaid back to the buyer. The savings is not going to the patient.
So the patient is theoretically let me hear, am I hearing you? The
Right.
patient is paying a cost through their insurance for the drug they think they're taking, but they're getting a
Right.
substandard drug.
No,
It's
I
still
can't- I
standard of
won't-
care.
it's substandard of care. It may not be a substandard of drug for certain people, but you
Right.
may not be getting the right drug for you.
It's right for you. That
For you.
lack of personalization is there, but it
And-
still is the standard of care. It's in the
I'm-
class of drugs that are standard.
So here's a good example. Let me say, we're looking at bone agents, right? Now there's like a zoledronic acid or recast. That drug has been reported by the FDA to say, okay, this drug is not a drug you should use if you're on a diuretic. And people who have high blood pressure, like the majority of Black folks, have high blood pressure and they may be on a diuretic. But do you know that this drug may influence or trigger or impact your kidney function and cause kidney damage? Now, an Xgeva or a Prolia drug, which is totally different, works at a different mechanism.
Right.
But they're still driving people to this drug that can cause damage. It may work for other people, but it's not the best drug for you because it may cause kidney damage. But they're still pushing you on that.
This is frightening. This is frightening to me, like, because as a patient, how do you even know any of this is going on?
That's the problem. You don't.
Melissa, how did you hear about this again? Tell us again one more time. How did
Actually,
you get on your
I was
radar?
speaking with a colleague of mine about, different obstacles in healthcare. And she said something, yeah, like step therapy. I'm like, what is that? And I Googled it and I saw this Washington Post article and it was jarring when I started to read what the implications were for patients. Like I mentioned, not just cancer patients, but those with skincare conditions, with Crohn's disease. Even like my father just recently had like something going on with his hip, and I was talking to him about it. He's like, I can't believe this is legal.
Yes.
That's how I first heard about it. And I thought as an advocate, I feel like it's my responsibility to bring things to the surface that are happening that we don't know about that are impacting our care directly.
I don't know. So Mo, you're the doc. Keith, you're the doc. You're prescribing medicine to a patient. So how does it even come across your radar screen? I mean, do you prescribe a lesser drug? Or does it, so you prescribe a drug. So what happens after you make the prescription?
So after you write it, and Dr. Keith, you probably can talk about this a little bit better than I can because I get right to the punchline. Let's say
I'm just letting Mo just take it there.
Listen, right. So my patient's got a rash, they got a nausea, they got something, whatever it is, and I prescribe that thing. And then I get a call from the pharmacy or the patient who says, you know what, this drug isn't approved, but this one is. Do you want to switch to this one? And they send you some paperwork and fax it, and they'll say, okay, so you can approve the generic or that you can approve this lesser thing. And then the patient may be none the wiser. The doctor may just do it in the office and sign it off and say, okay, go ahead and push forward that other thing and use the other alternative agent. And then the patient will get that prescription and say, oh, I thought the doctor prescribed me this. I guess I'll take that. And then the conversation may end there.
Mhm.
It could be the patient says, well, Dr. So-and-so prescribed this for me. And then they'll come back and call the office and say, well, why can't I get blah, blah, blah? And the office is like, well, we don't know. And then the insurance company says, no, that's not approved. That's not covered, right? You need to do a prior auth, or you
Yeah.
need to do a peer-to-peer.
You see, you
Now
see
you
what
gotta
they
make
said? You get a prior, you see that little trick? Oh, you got to do a prior authorization.
prior authorization to do that. You didn't know, but you needed to do it prior before you didn't know that you didn't know. And or then you got to sit on the phone and you got to do a peer-to-peer with someone who may not be in your specialty, someone who may be an allied health professional and not be a physician at all, right? Or someone who has absolutely no knowledge of what is going on with your patient. And that is where I close the door and we have a real candid conversation, because when it happens for, and this is for imaging, especially because, in my realm, I order a lot of imaging, MRIs, scans, et cetera. When people start, saying that what I order isn't approved, then we have some conversations.
Right.
And that's when I start having to take some names and start having to say, okay, so who's the person I need to talk to? And so you who have never seen my patient before are trying to tell me that this is what my patient needs according to whatever your algorithm is, but you have not seen my patient. And here you are weighing in on the treatment for my patient. So your name, Dr. So-and-so, is what? Because here you are, and then they get real testy and they say, okay, well, let's kick this up the next level. Or you know what, we're going to close this out and we're just going to start this process again. And they put you in with somebody else so you can have a different conversation with them.
Wow.
But you see what Mo is saying? Mo is giving you a narrative on what it takes to get the right care for her patients.
Yeah.
This wasn't a 2-minute discussion like she summarized. This could take her morning.
Yep.
And so they know these little things to change its utilization management. So
fancy name. Yes.
Fancy name. It's like, oh, well, and if they don't get you with, okay, prior authorization, they run you around. Then did you think about this? What happens is like, look, we'll pay for the medication, but we're only going to give you enough money to have 24 days per month.
Wow.
You see that?
Right. Like the other 6 are going to go away.
Yeah.
Right.
And the thing that burns me up about this too is, someone that's being treated for cancer, there's so many financial burdens already and stressors, and am I even going to live? And then when you have to start making phone calls and rallying and going through layers, that's when I say Ricky, you probably agree. That's why advocacy exists, because the patient, the burden shouldn't be on them like that.
Nope.
Have to fight for their care like that.
No, but we can't even really help them without being armed with the information about the drug. So
or
I'll name a drug. I'll say I never heard of that, but
it's something. And Melissa, you may not be aware of this, but back in the day, there used to be something called a green book for Black folks. So when you're traveling around the United States, you got to know where you can stay, what store that you can shop from that's safe in the United States for Black people. For cancer patients, we need that, because what insurance is best for you? And see, then you can't get in an insurance. It's almost like if you have a chronic disease, you're going to have to start thinking about how to design a roadmap. Okay, if this fails, what's the next treatment? And do I have insurance? So you have to be prepared to know that your insurance will cover the next treatment. Or what'll happen is they can tie you up, not for like 24 hours, but for months. And that to me is frightening, especially for a cancer patient.
Yeah. Well, that's what metastatic patients are doing right now. So literally when they start on a treatment, I say before they're like even, three infusions into the treatment or whatever, 3 infusions into treatment, they're looking for what they can do next.
Yeah.
Because they want to be prepared if they have a progression. So literally every metastatic patient I know, as soon as they get into a drug treatment or a treatment regimen or a trial or something, they're thinking about, okay, if this fails me, what am I going to do next? 30, thinking ahead.
But see, is that because they've spoken with you and they work with advocacy organizations like yourself? Because the average person is not even is praying that they get it back. So they're not even thinking about prepping
Well,
for it.
yeah, well, maybe we've helped them think about that, but I don't know. I think it's an innate metastatic breast cancer trait
Mhm.
that you are, because you don't, when you're stage 4, you don't really have a lot of hope in
Mhm.
our case, because the disease is so fatal and bad. So if you get some kind of inkling of hope, you're going to take it.
Mhm. And so on my end with prostate cancer, when you hit stage 4, people are wrapping it up. They're not even thinking
That there's more.
there's any more. They're getting they have, anytime you can ask anybody from on the street, and if you say, well, the person has stage 4 disease, they'll get sad. And it's like, oh, they don't really have a long time to live. They go to like a soap opera or a television,
Very
got
realistic.
6 months to live, and then that's it. Versus, wait a second, okay, there's this that I can take, and this, and then, and that's why I think that the advocacy organizations and the survivors that work with us are so important, because, and that's why Ricky and Melissa, you guys are so important. It's because you've had the disease and you're 16, years out.
Yeah,
So
together.
get this, right? I just Googled, because I'm like, okay, so we have advocacy organizations devoted to everything.
Right,
everything,
right.
Are there any advocacy organizations devoted to utilization management? And advocating in that space.
Such a great question. And so because I've just started my project here, I actually recently, and I'm going to have the podcast episode is coming out in a few weeks, Triage Cancer. Feel free to drop the link. They are a wonderful organization. I had never heard of them before, but they're very well known in the community. And
.org.
Yeah.
Yeah.
exactly. And you can actually contact them directly and they can help you if you are hitting an obstacle.
Mhm.
And that might be the only one, because I've done a search here to really try to see, and even before this show, who's out there who's doing this. And I think every advocacy organization really ought to have an arm to help people navigate this. And it's why the field of financial navigation is becoming so important.
Right.
And so, I talk all the time about my hospital and how we have a financial navigator. She took specific courses in how to help people navigate their finances and how to look at what their copays, deductibles are, what insurance plan they have, where they should maybe switch if it's open enrollment, and where are the resources to help you navigate this. But a subset of this also does really, I think, entail utilization management and probably looking at step therapy and advocating in those spaces too. But this is education that we can provide to advocacy groups, so that we can feel empowered and have folks who can help in this regard, because there's just not enough of it, and it's sort of hidden in other organizations' missions. But something devoted to this to help patients understand this and to advocate for this type of change. This is policy change. When we talk about what policies can we put in place and what should we be advocating for with our legislators, it's these types of things, because this red tape holds up care. It erodes trust. It creates confusion. There's so much to say.
Will not get well necessarily, right? Like, you go in to take medicine, you sign up for your chemo, and then you're getting a less than optimal drug, and that could maybe not work for you, and you're losing time on your disease. We don't have time. We don't have time.
Not acceptable, because the science is there. Your doctor knows what you need. So why should there be a roadblock to your life? No one should, everyone's entitled to have, if we have the science, no one should be denied that.
I will say, let's play devil's advocate though, conversely, right? Because the whole reason this field came about was to try to curb healthcare dollars and healthcare spending. So how do we then balance the need for giving patients what they need with excessive healthcare dollars, because pharma can then raise the prices and charge whatever they want for XYZ drug, right? So where is the balance, and where can this conversation be a bit balanced? Because I have a feeling as a result of this, Dr. Keith, we have a lot of advocates who are really, really angry and wanting to take on this, this issue. But I think also we're going to have to figure out how do we not drain our already drained healthcare system?
But can I ask you a question?
Yeah.
Okay. Can we go one level higher?
Please take me somewhere that's not here.
I know.
So when we were kids,
Crazy to me,
when you
crazy.
were kids, my parents used to put the cookie jar on top of the refrigerator. Because if they left the cookie jar on the cabinet, I'll have my hands in there eating all those cookies.
Right.
We really have to have greater transparency with the pharmaceutical companies. Because here's the deal.
They don't know. We don't know what's going
The
on.
pharmaceutical company, the PBMs are kicking back to not to the pharmaceutical companies, they're kicking back to the payer,
Right. Right.
If they get a savings, say for example, we save you $50 million. So what we'll do is we'll give you back 10. Instead of that 10 million going to the help to the patient to cover their reimbursing the patient, they give it to the payer.
Wow.
So one thing is that managing these organizations, you can't have a payer that owns a PBM or pharmacy benefits manager. And we have to have let's just start at greater transparency so we can see what's going on. See, the reason why you don't know it exists is because they're keeping it from us.
All right. So I just got diagnosed with triple negative breast cancer, stage 3. I walk in, I feel like I have this diagnosis. I go to the doctor, they say, okay, Ricky, we're going to put you on TAC or whatever the drug regimen is, right? I'm like scared to death. The C word is in my face. I have no idea what this whole course of action is going to look like. And now you're going to give me a drug that's suboptimal that I don't even know what's going on.
My issue is that you don't even know that as the patient it's suboptimal. Now,
Right.
if you're working with Mo, maybe Mo says, look, this is the best thing for you. This is what we want to do. And then Mo may come back and say, hey, your insurance company may hold you up on this. But you have your nurse in their hospital that is financial navigator. They have social workers or people inside the institution that are going to help you navigate, because you can't do this by yourself. And if the doc isn't open and said, okay, I'm prescribing this, and I know I'm in the state of Virginia, and I know that there's 5 different insurance plans that are out there. I know that this patient is not going to be able to take this because their insurance is not going to cover it. So is that the end? No. Then somebody has to contact the company, the pharmaceutical company, because they may have programs that are available to help you.
Help the patient, right?
Help the patient. But you're going to have to, one of the major things that has to be done is to address the bureaucracy that exists between the payer and the patient and the doc, and really the patient.
So the patient, though, is sitting there not even knowing that this is all going on, right?
Mm-hmm.
So how can the patient even do anything if they don't know that they got a suboptimal drug?
Well, but that's where no matter what, you have to recognize why we're so important for the
But
patient.
how would I even know to help them? They call me and they say,
Well, no, but first, I'm just saying we as an organizations are important because we're having this discussion right now. So they're becoming aware of it.
Right.
So,
the first step is really just that was my goal, even with the pot. It was like, I know that I can't change this overnight, but the first thing is just heightening the awareness to even know that it exists.
right,
Ask the questions.
right.
and then you can talk with your doctor. Is this something that's regulated or controlled by step therapy? Is this the best care? Because how many patients are going to ask their doctor, well, is this the best care that I should have? Versus a doc looking at you and saying, this person doesn't look like they have the economics. They're probably going to have weak insurance, so I'm not going to offer them that care.
But they might just say, you know what, the last time I ordered this, the last 5 times I ordered this, it tied up my whole whatever.
Yeah.
And it made me late for clinic, and I got dinged, and patients put bad reviews on Google, and they said I was always late and running behind and blah, 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 blah. I'm not ordering that drug anymore.
Right.
I'm going to go with this. It's standard of care, and this is where and it's unfortunate and it's maddening. I put in the chat ACCC. ACCC has great resources on the web, financial navigation, on advocacy in this space and understanding sort of how to navigate the finances of your cancer care. But it's not an easy question to answer, even if you knew enough to ask it. Because the reality is that they hide the cost of these things from the physicians as well, so that we cannot advise you on the cost efficiency or the nuances of efficacy all the time, right? That data isn't always just readily available, like, hey, Prilosec works better than, you know, whatever. And it's not always there. You got to dig and you got to probe and you got to do some research on these things. Sometimes
I'm scared. How am I going to do research on this? How come
us,
Yeah,
right? To
right.
answer the question, it's not on you, the patient. I mean, eventually it is after you try 3 different drugs and it's not working for your reflux, then you're like, okay, what the hell's going on here? In
Right.
cancer, you don't have that luxury.
You don't have the luxury. You don't have
Right? Like in bone density, osteoporosis, you got to try 4 different things before you get the one shot that really probably will work the best for you.
Wow.
Mhm.
This is really frightening. This is really frightening. All right. So
And then that's why even with that bone density, that's why it's very important for you know, in the prostate cancer space that we were able to get Xgeva as preferred bone treatment for men with metastatic castration-resistant disease, and that should be something that from breast cancer that should be made available for women also, and it hasn't been done as of yet.
Right.
So
So
what was it that made that available? Sorry to cut you off, Ricky, but was it advocacy? Was it advocacy by physicians, by patients, or by both?
It was advocacy. We had to push that very hard. And then
And who's the we?
Hmm?
Who's the we? Was it physicians that had to push back and push back? Patients.
Finn. Because so what happened is that they've been working on it for a long period of time. It just took time to really push it through. But advocating from the perspective of I mean, the science was there, the literature was there that, you know, advanced disease, metastatic disease, and the drugs that were available weren't the right drugs for people who have high blood pressure or take diuretics. So that information was there. And then Black people are more likely to go into renal failure and have renal disease. And there are more Black people on dialysis. When you line up all the facts, then the best choice is this one drug.
yeah.
So, and so that's kind of what we have to do is it is a fight. We have to just prepare the patient to be able to ask the question of their doctor. We have to start looking at making sure the patient has understanding their insurance that they have.
Right.
Because that's why I mentioned Virginia, because I came across a person who said they had insurance. And then what happened was they had a low-end insurance that didn't cover the chronic disease.
I know, you know, when they started doing Obamacare, they had so many different loopholes to keep people from trying to pay a high deductible that people don't even know what they're covered.
Yeah, they don't even know what they're covered.
They don't know what they're covered for. And then they get this warning, oh my God, well, no, we don't cover your drug. Like, WTF, you guys.
Mm-hmm. And
like,
they don't cover your drug. And then especially, that's why I said, if you have a history of cancer, then you need to be guarded and be prepared for knowing about your history, knowing about the cancer. And this is kind of what we can advocate, but being very guarded on what insurance you have.
Right. So I think this needs to be a probably almost a 3-part series, right? Where we've started this dialogue, and now we really probably need to invite the pharma companies and somebody to talk about how this plays out on their end, and invite you know, someone from the payer side and really talk about how this plays out and why this came into being, and what this means from their perspective, and really try to hear all of the sides if we're going to talk about solutions and know what to advocate for. And I think that's probably the part 2 and part 3 of this. If you all would stay tuned, because we're going to try to bring the rest of this. Melissa, you come back with us, and let's get a few more voices at this table so we can stand.
I love that idea. And
And-
All
Yeah.
parts of it.
And
You
you
know,
know, it's bigger
I
than
like to have, I
cancer.
like,
Bigger than cancer too. I think we should look at some other drugs, you know,
the Psoriasis Foundation is a very, a good group too.
it's so funny. I was about to mention them because
Yeah.
they have a legislation by state map. I'm going to drop the link in there and I'm going to be speaking to those folks too. Really, they have a lot of information about step
Yeah.
therapy.
Yeah, because I spoke with them at the beginning of the month. And if we're gonna we can bring those folks on. Political leaders, I know that are a Democrat. I'm in Massachusetts, but in New Hampshire, they're Maggie Hassan, a Democrat, supports a legislation called the Safe Step Act. And so we might be able to get a list of her colleagues throughout the United States to support it, because there's a political component. I like what they're doing, and that's why I said they're at least are starting somewhere.
right.
Because one of the things that really was frightening was there's no guidelines in place. So what they, generally speaking, they're requiring in their act that health groups respond to exemptions. They want to be able to, a person can apply for an exemption. So that's what we can do, is make sure patients recognize that there is step therapy, there may be some exemptions involved,
Right.
and that you can apply for an exemption.
Right.
Because what happens is, they need to stratify it. So the payers need to be able to should respond in 72 hours and not 3 months.
Not 3 months. 3 months is.
If it's a life-threatening, if it's
Yeah,
life,
if you have stage 4, no. I mean, if you're late stage, there you don't have time to mess around.
but there's no guidelines in place. So that's why I said you're letting the kid with the cookie jar. You just like, I'm making up the rules as we go along. Say, well, we'll increase his bureaucracy, so they'll give up. And then while this Safe Step Act is because it also says that if it's life-threatening, which cancer is,
Right. Hello.
they need to respond in 24 hours.
I think this is a great topic for NBC Alliance also,
Yes.
for San Antonio, right? This is the kind of debate and conversation that probably needs to happen in those spaces too. But our next conversation, we should look to invite someone from the Metastatic Alliance also and start talking about how this impacts, how this impacts those who need it the most at a very, very critical time, because they don't have the time to wait 6 months and try it out and see if it, see how it goes, right? You need the highest level of evidence, and the highest care and efficacy that you can get, and so we want to try to put some resources in the chat. I know that we put the podcast into the chat, and if you get a chance to listen to it, Melissa Berry is a skillful, masterful interviewer.
Oh my goodness, you're making me blush, Dr. Mo. Thank you.
You ask questions people want to know, like you get to the real. And Dr. Keith he keeps it real. So y'all,
I think I'm so, this is an important topic, and it's just I think we can basically all learn together, because what I don't want to do is anyone tuning in to be frightened or confused.
Oh,
we're not here to scare you. We're here to inform you, I think, and just not to overwhelm you. First step, this is what step therapy is. It exists. And now you can come along the journey with us as we unwrap it and figure out how can we overcome it as patient advocates, patients, and medical care providers.
Right.
And that's why you guys have a very powerful organization, very powerful group. And in San Antonio, I think that would be an excellent opportunity to bring this up, because every breast cancer patient in San Antonio should know about this. They should be able to contact and look at this. This is bipartisan, because Senator Murkowski out of Alaska is a Republican, and Maggie Hassan in New Hampshire is a Democrat. So it's bipartisan support. So we should be able to get this bill in the office. And then the other thing that I want to tell you about is remember with the players, how can you have a payer own a pharmacy benefits manager? Where's the checks and balances?
Yeah, I know who's running the farm, right?
Yeah.
chicken in the hen house or whatever that
Yeah.
quote.
And so all these little nuances that we're talking about today, that's where I see, that's what I'm frightened about is that,
Who's in charge?
you can't even, they don't even tell you, it's not even public record of how much, well, somebody, you can call it a rebate. I call it a kickback. So however you want to say it. But the point is,
The kickback.
it's a kickback. And so
Somebody's making a profit off of you getting less optimal care.
that's it, right? If we
That
can
is
get you,
just
we can.
insane.
Mhm.
It's insane. Like, and we don't even know who's doing it. You know what I mean? Like, it's insane.
Oh, I mean, they're right out front. I'm just saying, the payers are the payers, and the PBMs are the PBMs. Those pharmacy benefit managers. They are the buying groups.
I think we need to write an article about this too for Black Doctor. I'll get work on that. We need to write an
That would
article.
be amazing. I would be happy to help you with that.
Help me, Melissa. Help us
All
write
hands
it.
on deck.
Because it's not out there, and we need to do a pan,
Yeah.
like a pan cancer,
Right, it's
because a pan
and
cancer
everything. It's
concern
high
about
blood
step
pressure,
therapy.
diabetes, it's all the drugs, it's everything that, you
Mhm.
know, that people are taking. I mean, if
I
we're,
mean, but think about it. Think about having a little kid, your child, and
Yeah.
they knowingly would allow you to put your child through torture, and
drugs
then
may not work.
that may not work. I can say that. I mean, that's, yeah, okay. You want to do it for an adult, but you got to at least provide the child, give the child a fighting chance, because developmentally, you can't shortchange him.
Melissa, why
It
do you
starts-
think, why is this coming out now? Because you're bringing it out, but like, why isn't this in the media? Why aren't people talking about this? Why is
Actually, it's so funny you should ask. I was starting to do my homework on this, and a few months ago, there was actually, just posted it, an article in the Washington Post about fail first step therapy. And
fail first step, even the
Mhm.
name, right?
It's right. It said, that's why I said fail first. It's right there. You got to fail.
Yeah.
We're sorry you failed and you almost died.
Right, we're sorry you failed, that you
Mhm.
got the wrong drug.
But
That's
why
a
is it
good
the
question.
failure of the patient, right? Like I hate that. It's like saying people lost their battle, right? What did it's the terminology around all of this even needs to change.
Right.
And there's so much reform that needs to happen that we got to be strategic about where we start and how we're going to make it there. But you're right, Dr. Keith, is that this is a bipartisan issue. This goes across the aisle, and everybody across all disease states should be fairly outraged,
Right.
because
And we should, and this act should be passed. You guys got some, Ricky, you got some political contacts. This is like, it should be, why is, you're at the White House. Shouldn't this be right up front? Did you hear about this at the
Right
White
up
House?
front. I'm gonna bring this up to, definitely, and on, we're on the President's Cancer Panel and the Moonshot thing for the National Minority Equality Forum. I'm gonna send them all an email and say, what is going on with this and what can we do? Also, we've been working with a bunch of Congress people from CBC, Jasmine Crockett, remember, Mo, and Robin Kelly, Congresswoman Robin Kelly.
Yeah.
Do a little outreach to their offices. And even, I spoke on a panel with Debbie Wasserman Schultz, her cancer event last week in Florida. So I think I'll do a little blast to the Congressman people that we know about, and, the breasties that we know too, especially, and see what's going on, if there's anything even happening in these conversations, on the Hill about this horrible, horrible thing.
you know what's really interesting, full disclosure, like I was talking to my social media consultant about our program, and she was like, it'd be great to have some infographics. So I'm looking for infographics or stats on step therapy specific to cancer or breast cancer.
Right.
And there's little to no,
But-
there's very little information out
But
there.
there's not that, I'm just saying, there's not. This is what we're
That's the
saying.
problem.
It's not. We're not talking about, this is
Yeah.
only a decade old, and it's creeping in there, and more they're getting more and more control over the economics. The objective is to save money. And the point is that they're doing their very best to save money,
Yeah.
but that some of it is
At the expense of life,
patient.
the patient, save money for what? You know what I mean? Like, who's the victim of that? And I think it's just so unclear even how a patient would know that this is happening to them. That's the scary part to me.
And then this is why those guidelines, I mean,
Yeah,
the
we need some
patient
guidelines.
has the ability
Yeah.
to ask for an exception.
Right, yeah, or you know what, though? It shouldn't be happening at all.
Yeah, but it's gonna happen. See, the deal is, it's gonna happen, but it's gonna happen, but we can control to what extent it happens. That's why I said before,
Yeah.
if a doctor says, well, you don't qualify for this, you're not gonna be left for 3 months without trying to try something. If
Yeah.
if you fail, or if you ask for
Yeah.
if you ask for what is it? Yeah, if you ask for an exemption, then it shouldn't take you a long time to get it, 72 hours. If it's life-threatening, 24 hours, but they have to respond. We have to get them to do that. And so it's just like there's some of my notes. It's like, one, patients, if you've already failed on this drug, they can't force you to take it again.
Well, also, how do you know you failed, right? So you get this drug, you don't know that you're on the wrong drug, and then you're not going to get scanned for 3 months. So at the 3-month mark, you show progression, you know the drug has failed, and you're like, well, my chemo didn't work. And you're thinking you got regular chemo, not some suboptimal drug, and then you're in a worse situation because you can't even know what happened to you, right? This is really scary. This is really scary, and I think we have to figure out how to fix it. I don't like this
Here's
at
the
all.
thing, like it's scary at the same time, like it's empowering, like just to know that it exists. Like, okay, let's
Yeah.
start it. This is the first, and I hear you, Ricky, because it made me angry. Like when I first read that Washington Post article, I'm like how, like my father said, he's like, how is this even legal? Like,
How is it legal? How is it legal?
But that's the point. How it is, you have
How is it ethical? This is
you have a group of people that have organizations that have money that can influence it. And their objective is to save the buyer money, the payer money. That's what their objective is. They're not on the side. That's why earlier I grouped it up into three groups. The patient and the physician on one end, the PBM and the payer on the other end, and the pharmaceutical company is sitting there with their hands behind their back tied, saying we can't even say anything.
And where's the patient?
And the patient's over there, and the doc, the
scared.
our objective was always been the clear, do no harm. That's what our objective was. And now all of a sudden, the PBM / payer slid right in between the patient and the doc, trying to say, well, you know what, try this. This is what my MBA said about kidney failure.
And they'll show the data. They put it in their insurance guidelines, though, and this is where it gets tricky because they'll say, "Oh no, you can't have the genetic testing kits, right? Which companies and which kits can you use?" Despite the fact that there might be more VUSs in certain populations, there's a lot of stuff that they write it into their policies based on whatever data that they choose, and then that's how they justify it.
But see. But see, more, what's so interesting about this is that we are not a monolithic society.
Exactly.
We have sequenced the whole human genome. We know majority of all the genes that are made up. We can segregate people according to races, different locations in the globe where their families come from. And we know genetic testing is important. So how do you stop a person who has a family history of being tested to look for genes that could benefit them? And especially, this is what's scary. Personalized medicine, precision medicine is based upon your genetic makeup. And they're designing these new drugs that are based upon you knowing your genetics. So if I don't take a genetic test.
How do I know?
I won't be.
How do I know?
Look at that. If I don't have access to a genetic test, then I won't have access to the drug that might be of better benefit to me.
Wow. Wow, 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 you guys.
So if you're just tuning in, we're closing up here, but this is only the beginning of this
No, this
conversation.
conversation.
I know I
And
dropped a bomb on you. I know, Ricky, like it was a couple of months ago. I'm like, did you ever hear of step therapy? You're like, what? What is that? I'm like, okay, to be continued. So here we are. And so thank you for having me on. And like, so this is the beginning.
you gotta
Because-
check out the podcast.
Yeah.
Dear
How-
Cancer.
Here's the
think
podcast.
about this.
To come
Think
back
about
with a
this.
solution.
How-
We're gonna
think
come
about-
back.
So think about this. Think about why this particular episode was so important. Because nobody's talking about it.
So if you just got diagnosed and you just got prescribed drugs, you need to go back and ask your doctor, ask your pharmacist, ask everybody that's sort of in the chain of how you got the drug, what you're taking. And did you get the drug that you thought you were prescribed? And I think that's the best direction we can give you right now. And we're going to go try to figure this out and try to come back with another show with some solutions. But I think anybody right now, if you just got prescribed medicine for anything,
Right.
for anything, you need to go question the doctor, question the pharmacist, and make sure that you got the drug that's going to give you the best care. That's
And
what
also call your health insurance company and ask them if they have a step therapy protocol in place. They have to tell you by law.
And
I'm going to put that in the
Know
chat.
that.
yes,
Yeah.
and if they do, and you reach that roadblock, remember that you can also reach out to the pharmaceutical companies that may have special programs to help you address that shortfall in cost.
Yeah.
And maybe
I
that's
can't even imagine what Medicare and Medicaid are doing, right? They've got to be cheating you out.
because we're looking at the average person is not educated, and I won't say educated, not aware of the nuances of payment for their medication. They're just get a medication.
Ricky, that sounds like the next part we got to talk about too, because what's happening in the Medicare and Medicaid population as well. So
I
there's
know.
more.
Can you imagine?
More
But that's why I said
specific
if you take a look at it, I'd like to break down the Safe Step Act, because the
Ooh.
Safe Step Act addresses what's going on.
Let's do it. Let's do it. So we hope this has been relatable and reliable and real. And we know it was, and we hope it hasn't been too scary, but we think you should be aware. Right. You should be aware of what the barriers are to getting the most optimal care, the most optimal medical therapies, and to know that those barriers exist, not just for you as a patient, but for us as healthcare providers, and that we got some work to do to partner together to make this thing a reality for everybody. So this is something that we can all agree upon, is that it needs to happen, and it needs to happen fast. So that's my last final words. Dr. Keith, Melissa, what do you all want to say, for people to take with them when they leave this conversation, and hopefully click share, and share it widely?
Thank you so much, first of all, Ricky and Dr. Mo, for having me on your amazing platform and show here, and for Dr. Keith for doing the honor of being my very first step therapy expert. I wouldn't have it any other way. And I encourage everyone to go to either on Spotify or Apple Podcasts. You just look for Dear Cancer, I'm Beautiful. And we just recently had this episode, and the link is here, right here in the comments, the step therapy, Your Voice, Your Health episode. And I encourage you to listen to it, because we really break it down into very digestible pieces and steps. And there's some really great tips in there. So thank you again, all of you.
I just posted it again. It's in the comments.
Awesome.
And I would like to, again, thank you for inviting me back. One thing that's important is that I want the audience to recognize the importance of having a reliable source of your information. And here, we're going to do our very best to give you the most reliable information so you can be prepared for your cancer journey or chronic disease journey. But the most important thing is having a good understanding and knowing that you have a reliable group of people who you can reach out to, who you can trust to help you along your journey. So thank you for tuning in.
We're here for you. We're here for you. We're here for you. Whoa, all right. So next week, Mo, we're talking about hospice.
We are, but this Sunday, before we get there,
I
we're
know,
doing a
That's
special
right.
episode of Links in Pink, right? Because we wanted to highlight the work that the Links Incorporated are doing in the breast cancer space, in advocacy and research, surgery, medical oncology. So this Sunday at 7 p.m., we hope everyone will join us for, I think, is it a full hour, Ricky, or is it a 30-minute
Full hour,
series?
whatever we want. We'll get, and we've, so far, I think we've got 5 Links doctors signed up.
Wow.
And if you're not a Link, you should watch anyway, but we're doing a special episode for our Link sisters and they're doing some really great work and we want to showcase it and talk about it. And that'll be our last episode during
Breast Cancer Action Month.
Action Month. Breast Cancer
And
Action
there'll
Month.
be some action for the links too. I think it's important for organizations like that with chapters across the globe to really talk about what can we do from an advocacy standpoint that goes across all health disciplines. And it's just one of those topics, right? It's not just kidneys, it's not just breast. There's something for us to do in advocacy for our sisters, our brothers, our folks, our communities, our own, saving our own lives here, our children.
Yeah.
So Melissa, thank you for bringing this topic to light.
Thank you, Melissa, for bringing
Everyone.
that up.
Thank you.
Thank you, Dr.
We'll
Keith.
see you all.
And we also want to give sympathy to Richard Roundtree's family.
Yeah, we do.
He died of pancreatic, but he's a breastie.
Yeah.
I
And
met him a
breast
few years
mutation
ago.
care.
Yep, I met him a few years ago, and I had a really great conversation with him about his breast cancer.
Yeah, and men can get breast cancer, and the rate of male breast cancer seems to be increasing.
Increasing.
It's
So
incredible.
hashtag check your chest. If you're watching, send
Yeah.
this to the men in your life and let them know that, they too should be performing self-exams.
Yeah,
So,
yeah,
Hashtag check them.
yeah.
Yeah.
All right, breasty love. Thanks, you guys.
Thank you, everyone.
Guys. All right.
Yeah.
See you
Well,
soon.
see you soon.
See you Sunday at 7
Monday,
Eastern
7
time.
p.m.
Eastern
Laptop
time,
time.
and then next Wednesday at
And the pink attire.
We like that blue though. That blue is hitting.
know,
It's
this is
balance.
good.
It's balance.
Good.
I'm just trying to keep up. I'm trying to be that thorn.
Oh, there's
between the
Harper.
roses.
Harper's trying to say goodbye. Yeah.
Oh,
And Harper's
bye.
a thing.
Harper's like, what's for dinner?
Yeah.
Oh.
See you, everybody.
Bye.